Thank you, Anne.
Thank you. Thank you, Liz, and thank you to my great panelists who are with us this morning, afternoon, evening. Greetings to you all. I'm really happy to be co-chairing this as the immediate past president of FIGO. Regards from the current president, Professor Frank Lowen, and I'm co-chairing with the ICM Chief Midwife, Jacqueline Dunkley-Bent. And I want to really give you the recollection on the 5th of October, where we had a unified presentation of the consolidated guidelines, WHO-FIGO-ICM. So I'm really excited. 1 month, 8 days later, we're back again. The fight for PPH elimination continues. And what we really want to propagate is the fact that this should be literally treated as the new war. It must be eliminated. It must be addressed. Preparedness, recognition, response, and review must continue. So this is the first dissemination exercise, and we're hoping not only will you listen, you will also be able to disseminate to your fellow colleagues and pass the baton. So scale up, scale up. I won't say much. I want to hand over to Jacqueline to give a few remarks, and then we must move straight into what has brought us this evening. Thank you very much.
Absolutely, Prof. Chiara, always a pleasure to stand side by side with you, midwife and OBGYN. You know, our collective responsibility lies in ensuring that every birth takes place within a system that empowers all care providers to act swiftly and collaboratively. By working together across professional boundaries, we can prevent avoidable maternal deaths, strengthen health systems, and uphold every woman's right to safe, high-quality care during childbirth. When the stakes are high, your actions and those of the decision makers or inactions could make a difference between life and death. You are going to hear some great presentations now. So let's just start this amazing webinar, and I'm going to hand over to Femi. I think, Femi, you're next up. Over to you, Femi.
Thank you very much, Jacqueline. So colleagues, welcome to this webinar. I'll take the next 10 minutes or so to walk you through where we are on the global postpartum hemorrhage roadmap, specifically the progress that we've made under the norms and standards strategic area. Next slide. So as many of you know, postpartum hemorrhage continues to be one of the most urgent drivers of maternal mortality globally. So the roadmap that we developed with partners over the last 2 years aims to coordinate and accelerate action across partners, across contexts, across countries. And a central pillar of that work is the strengthening and harmonization of the global norms and standards so that countries can rely on consistent, high-quality guidance to be able to prevent, diagnose, and treat postpartum hemorrhage. But before we look at the PPH normative work, it's important for us to remind ourselves of the scale of the challenge. At the current pace, as many of you know, if you've read the trends in maternal mortality, the world remains off track for SDG targets 3.1 by well over 1 million lives. And obstetric hemorrhage still accounts for up to 27% of maternal deaths globally. But when we look at the data carefully for postpartum hemorrhage, this translates to about 45,000 deaths, arising from roughly 27 million cases of PPH every year. But we also all know that even with progress that we've made over the last decade or so, too many health systems still struggle to identify postpartum hemorrhage early and respond quickly enough. Next slide. So, as part of a global response to the challenges of postpartum hemorrhage, in March 2023, WHO and several partners engaged a broad range of stakeholders, from ministries of health to research institutions, innovators from industry and private sector, professional associations like FIGO, ICM, ACOG, NICE and other obstetric and midwifery associations, donor agencies, non-governmental associations, as well as UN agencies. And they were all involved in a participatory process that led to a global convening that was used to define priorities for 4 strategic areas to shape the future of postpartum hemorrhage. That was in research, norms and standard, implementation, and advocacy. But one of the key strengths of this roadmap, next slide, is the breadth of engagement. As I said, we had lots of people from all over the world, approximately a minimum of, I think, about 130 participants from more than 50 countries. It was that diversity that ensured that what resulted from this work is kind of realistic, is implementable, and is responsive to different realities wherever women give birth. Next slide. So the result of that convening was the roadmap to combat postpartum hemorrhage between 2023 and 2030. The roadmap is now available in all 6 UN languages, and you can access it through the QR code when you receive the slides. And this QR code will take you to the landing page that collates all of WHO's work on postpartum hemorrhage. What you should understand is that the roadmap lays out a comprehensive vision for ending the geography of risk. That is the unacceptable reality that a woman's chance of surviving postpartum hemorrhage depends on where she lives. It sets out concrete actions in terms of addressing key research priorities, developing harmonizing international guidance, supporting implementation by addressing the various bottlenecks, improving training, and so on and so forth. Next slide. So in late 2023, I think in November 2023, and in fact, about a month or so after the roadmap was published, WHO convened the Technical Advisory Group for Maternal and Perinatal Health Guidelines, which included the Executive Steering Group for the consolidated PPH guidelines. And this group advised on the key priority questions for the recommendations that will be consolidated. The steering group includes representation from FIGO, WHO-ICM, and they provided strategic oversight that we needed to harmonize the PPH recommendations that were previously fragmented across multiple documents, both from FIGO, ICM, as well as WHO. Next slide. So to support this partnership formally, our 3 organizations signed an MOU covering 2024 through 2026. And this MOU commits the 3 organizations to oversee the guideline development process, develop shared training materials, and work together on dissemination and country adaptation. This level of formal collaboration was unprecedented in PPH guidelines development, and it was essential for consistency and for scale-up. Next slide. I just want to show this slide to sort of give you an idea of the timeline for the normative strategic area of the roadmap. There are several critical milestones, from establishing the steering group through to adoption and adaptation. Next slide. And as you see, I'm pleased to let you know that all of the critical milestones have now been completed. And what is now left for us to do as a community is for all key stakeholders to provide technical support to countries to continuously support adoption and adaptation, as well as implementation of this guideline. Next slide. So all of the work that we've done over the past 2 years with FIGO and ICM has led to what we launched at the FIGO Congress. And that includes the consolidated guideline itself, comprehensive training materials. There's a WHO academic course that you can access when you get to the presentation by Sherry. And there's a forthcoming implementation toolkit. So together, all of these tools represent a major leap forward. And for the first time, I think the world has a unified evidence-based set of standards for identifying and treating postpartum hemorrhage. It is designed to be operational, it's designed to be practical and adaptable across settings. So with that, I'm going to pass it on to Yanis to talk about what we did and how we came up with the idea of revising the WHO definition for postpartum hemorrhage. Thank you.
Thank you very much, Femi, and greetings everyone. I'm presenting about the standard for postpartum hemorrhage, the definition for postpartum hemorrhage. The question is, did you ever wonder where did the 500 ml threshold come from? And why are we using 500 mLs and not another number? And does this number actually work for everyone? For every woman everywhere, and does the one size fit all? So PPH is commonly defined as the 500 mLs of blood loss or more after childbirth. But this threshold that's commonly used may not suit everyone. And there's probably not one size fitting all when it comes to blood loss, as women have different blood volumes or they may be anemic. And in the presence of anemia, one can get unwell and die even before this threshold is reached. So blood assessment can be subjective, and it often underestimates the amount of blood loss, leading to delays in diagnosis and life-saving treatment. We also do not know how good these thresholds actually are in predicting who will suffer adverse outcomes. And there are many attributes of a good disease definition. So most important is to allow health workers to recognize the condition as it presents in real life settings, enhancing the diagnostic accuracy and patient care. It should include measurable and objective criteria that reduce variability in practice. They ensure that diagnoses are based on defined thresholds rather than subjective judgment alone. And the definition should support effective management so that it will enable clinicians to initiate early and effective treatment. It should be applicable in diverse healthcare environments, from tertiary hospitals to primary care clinics, so that the disease is identified consistently regardless of the setting. And last but not least, it should be both sensitive, so identifies most women that will suffer adverse outcomes, but also specific, so identifies the women that are healthy, that they don't require treatment, and they should not have this unnecessarily. So it should balance the need to diagnose correctly without excessive false positives or negatives. Sensitivity is critical here for early stage or highly treatable conditions like PPH. Now, defining the disease is not as easy as it sounds. Typically, 4 approaches have been used. The first one is convention. And typically that involves a consultation where experts decide what the definition should be. These consultations are typically large with several eminent experts, and they may be leading to a definition that's adopted widely for decades for conditions. And this includes the postpartum hemorrhage one. So it's not ideal because it's not evidence-based and only relies on expert opinion. But it can be used where there are no data to inform the definition. A distribution-based definition uses data and breaks down the test results of a population where a judgment needs to be made about which results are abnormal. So for example, thyroid function results, you can say you're in the top or bottom 5th centile or 2 standard definitions away from the mean. Hence, this is an abnormal result and you will require treatment. Now, with this kind of definition, what we still don't know is how prognostic this result is. So were you really more at risk than to suffer adverse outcomes than somebody on the 10th centile? And why do you need the treatment and somebody else doesn't? So if you're looking at distribution alone, you won't get help with that. Ideally, we should be linking the distribution of the results to the outcomes. So a treatment decision is informed by your actual risk of adverse outcomes, and that means then you're developing a prognosis-based definition. Still, there's still the gold. So if you're moving up in the ladder, you should be aiming to have evidence whereby one definition has been used and compared to another definition, and that has been proven to produce better outcomes. And the definition that gets you the better health outcomes is definitely the one to use. Now, if we were to look at the origins of the 500 ml blood loss threshold, these are quite kind of obscure. So a quantitative threshold appeared in obstetric and midwifery literature as early as the 1900s. but this lacked robust empirical evidence. The first documented use of a quantitative definition was Williams' Obstetrics back in 1936, where PPH was defined as blood loss of 600 mL or more, based on observational data from 2 hospitals in the United States. Throughout the 20th century, both 500 and 600 mL thresholds were regularly cited, and in 1989, a WHO Technical Working Group on the prevention and management of PPH adopted the 500 mL threshold as a working global definition, noting that 500 mL is internationally accepted but nevertheless arbitrary. The definition established by convention became so established in everyday practice despite the little evidence to support them. If we were to challenge the status quo, we needed data. And the kind of data that will help us to inform new definition for postpartum hemorrhage, we need to speak to distribution and prognostic approaches at least. So we needed data on postpartum blood loss, and measurement need to be objectively measured and not visually estimated, as we know that this is inaccurate. And similarly for the other markers, they need to have been measured objectively in the 3rd stage of labor before a diagnosis of PPH was made. And the data from the clinical markers need to be linked to adverse PPH outcomes of morbidity and mortality. And if we were to harmonize data sets across trials, which was quite resource intensive, because it's almost like analyzing data from multiple trials at the same time, we had to make a pragmatic decision to include studies with over 200 participants. So for this work, WHO issued 2 global calls for data with good returns in terms of data sets and 38 submissions with over 500,000 women. We conducted also authors identified through systematic reviews with potentially eligible data. And for those interested to collaborate with WHO, we signed data sharing agreements and hosted their data in a secure portal. After review of the datasets submitted to WHO, 12 datasets were included in analysis from 312,151 participants. The data represented 84% of eligible data, and the most common reasons for excluding the data was absence of an objective measurement of blood loss, or the studies being too small, fewer than 200 participants. The available data were analyzed and informed the distribution and prognosis approaches. And here's an example of a distribution approach. So for that approach, we plot the number of women by their volume of blood loss. So most women lose around 100 to 200 mL of blood after birth. That's why you see the distribution being more frequent there. Now, the 500 mL threshold corresponds to 87 centile, which means 87% of women would lose less blood than that. And we'll be classifying 13% women as having an abnormal blood loss, and those will receive treatment. Now, this may be correct or maybe not. We don't know if the 87% of women below the threshold have actually 0 risk of adverse outcomes, and whether the 13% above the threshold will definitely go on to suffer adverse outcomes unless they were treated. So while these numbers are still are useful, it's still quite difficult to say if treating 13% of women after birth for PPH is too little or too much. For the prognostic approaches, we have more information. So we can see by the amount of blood loss if the woman suffered adverse outcomes or not. So here, the blue dots represent women without adverse PPH-related outcomes, like blood transfusion, morbidity, or mortality. And the red dots represent women with those adverse outcomes. Now, if we draw the line here at the 500 mL threshold and classifying whoever is above it as PPH requiring treatment so they don't go on to suffer complications, you can see how many reds and blues we have on either side. And what you can instantly see, it's not a perfect split. So many women suffer complications on the left side, and not all women on the right go to suffer complications. Now, the red dots on the right side are the true positives, and the blue dots on the right side are the false positives. But even so, we're classifying the blue dots here as false positives because there's still ongoing treatment happening. What we don't know is if they received treatment that prevented them from suffering adverse outcomes, or indeed the treatment was given unnecessarily. So it is hard to say, but it's not as bad having some blue dots on the right. So it could be representing successful treatment. What we don't want, it's definitely bad, is to miss women that would go on to suffer adverse outcomes. So these are the red dots on the left. For them, the diagnosis was made too late, and perhaps that delay could have been deadly. So with these numbers, we can go on and calculate the prognostic sensitivity and specificity for complications. And one of the key numbers we're looking is to minimize false negatives. So these are the red dots on the left. So not an easy task. As you can see, there's no single line that we can put for the blood loss that captures all of the red dots. So WHO set up a consortium for the PPH definition and analyzed the data available to calculate the prognostic accuracy of clinical markers of bleeding in predicting morbidity and mortality from PPH. The results were published in The Lancet a couple of weeks ago, and these are the results I'm presenting from this analysis. So we calculate the prognostic accuracy for objectively measured blood loss for each possible threshold of blood. And we found that, as expected, blood loss is a very strong prognostic clinical marker with sensitivities and specificities ranging from 70 to 80%, around 70-80%. Now, the 500 ml threshold, comparing to the other ones, reached a fairly high sensitivity and specificity. However, in this context, because we would prefer to maximize sensitivity, so not missing women who will suffer adverse outcomes, an expert advisory group convened by WHO was asking if we could aim for prioritizing sensitivity over specificity for sure, but also aiming for over 80% sensitivity. Now, with that goal, 80% sensitivity we're getting with a blood loss threshold of 300 mL or more. But this was coming at the cost of fairly low specificity, which meant perhaps too many women would receive treatment unnecessarily. So while we wanted to maintain a sensitivity of over 80%, we examined different approaches for improving on specificity. So we examined 3 different clinical rules for combining measurement of blood loss together with other clinical markers and see if we can improve the accuracy. In the first rule, in case any of the clinical markers was abnormal, that was classified as postpartum hemorrhage. And with this one, we got a great sensitivity, but a very low specificity. And in the second rule, we said we had to demand for both blood loss and one more marker to be abnormal for that to be classified as postpartum hemorrhage. And unfortunately here, the sensitivity dropped even though the specificity was rather high. For the third rule, and considering the 500 ml threshold already had a very good specificity and it was the standard criterion used, but we needed to improve on sensitivity, we classified PPH as anyone who had blood loss of 500 mL or more, and also those who had 300 ml of blood loss or more in combination with another abnormal clinical marker, so high pulse, low blood pressure, or high shock index. And this approach was trying to diagnose the women mostly with anemia or comorbidities that would not tolerate blood loss very well, and they were at high risk despite the amount of blood loss not being that excessive. So that clinical rule achieved the desired sensitivity with an improved specificity compared to blood loss alone. Then we examined the prognostic accuracy within population subgroups, and we found that the accuracy of this definition was even higher for vaginal births, with sensitivity of close to 90% and specificity of 80%. Which was great because that means we don't miss women anymore and we don't overtreat with this approach, women that give vaginal birth. Having said that, not the same could be said for cesarean sections. So here we didn't have much data for cesareans, and most of the data was coming from one trial that was conducted in France. And according to that study, the sensitivity was high, but specificity was rather low. So at this stage, we also needed to gather more evidence to understand about how feasible and acceptable this approach will be for these women and whether it will be generalizable. And we also need to bear in mind that at cesarean, it may be harder to interpret changes in hemodynamic signs in the presence of anesthesia, and some clinical judgment may be needed. So the prognostic accuracy data was very strong, but we could also aim for the gold. And we searched for therapeutic impact evidence, and if there are any studies that have compared different definitions for postpartum hemorrhage. So this was published as a coherent review a couple of months ago. And in terms of therapeutic data, what was found was mostly a subgroup analysis from the Emotive trial. In the Emotive trial, it was a trial that compared early diagnosis and bundle treatment versus usual care in 4 countries, but not all countries use the same way of defining postpartum hemorrhage. South Africa used the 500 ml threshold as a definition for PPH. Meanwhile, the other 3 countries, Kenya, Nigeria, and Tanzania, opted for both either 500 ml or more or 300 ml or more in combination with abnormal signs, whichever occurred first. And that choice was because they had high prevalence of anemia in these countries. And the results were quite astonishing because they did not end up overtreating, and they were much more successful with their earlier treatment and had great impact in reducing morbidity and mortality compared to using the 500 ml threshold alone. So we do now have the overwhelming evidence from actually all the possible approaches for a new definition that is most accurate and impactful. So the promise is great, but we also needed to see if we could actually afford it. So how much does it cost, and if it is cost effective? So we normally plot new interventions in a plane of how beneficial they are and how costly. And if you end up in the green, it's really not a question. So you're getting better outcomes and you're saving money. These are the interventions that should be implemented yesterday. But most interventions will fall in the faint green. So it means you get better outcomes if you can afford the price, so if they are cost effective, depending on the threshold you use. So you should definitely not be in the red. And even the yellow is not ideal because you're accepting worse outcomes, even though you may be saving some money. So what we found is that the new definition was in the faint green. So it was giving us better outcomes, but it was coming at a price comparing to the 500 ml alone. Now, blood loss combination with other clinical markers were more cost effective comparing to blood loss alone by a great extent, and they were closer to the bottom right corner. And what was also interested, as one would expect, because we're having better accuracy for vaginal births, the combination thresholds were now becoming close to cost saving. So it means we were saving money and we were getting better outcomes. So now it was becoming a no-brainer for those giving birth vaginally. And also needs to say that the cost effectiveness was also dependent from the background incidence of adverse outcomes. So where you have a high incidence of adverse outcomes, these thresholds were becoming more cost saving and the benefits were greater. Now, the last piece of the puzzle that we wanted to answer is if the new definition is acceptable and feasible, are we going to be treating too many women with the 2 criteria? So WHO with partners conducted validation studies in 6 countries and found that the incidence of PPH using the new diagnostic criteria is around 20% overall, 13% for vaginal births and 31% for cesarean sections. So in vaginal births, we're adding very few additional women who will be considered as having a postpartum hemorrhage that will require treatment, so around 2.7%. Now, for cesarean sections, it was adding a little more, so around 9.4% compared to using 500 ml alone. And that's also to compare with those who were using definition of 1,000 ml or more for cesarean section, where only 2.9% of women matched that definition. So quite a fairly low number, considering that most of the treatment interventions are actually also given routinely for cesarean sections like oxytocin and intravenous fluids. Perhaps the only additional intervention not given routinely would have been tranexamic acid, which is safe and effective when given early in the treatment of postpartum hemorrhage. So we expect that will be generalizable also for cesarean sections to use similar criteria. So our four take-home messages from this is that how you define postpartum hemorrhage matters, and you really do need global consensus if you're going to get the benefits. An earlier diagnosis approach results in reductions in morbidity and mortality in trials without increase in treatment rates. Treatment is safe and cost-effective, especially for vaginal births. And for cesarean sections, we result in higher treatment rates. Implementation may be problematic, so clinical judgment may still be required for its use. Great, that's all for me. So I'm going to pass over to Professor Aris Papageorgiou.
Thank you very much, Yanis. I hope I can be audible. These are the guidelines, so please use the QR code in order to access them. And there's a website there as well. My name is Aris Papageorgiou. I'm a professor of fetal medicine and obstetrics at the University of Oxford, and I was pleased to be able to chair the guideline development group that worked on these guidelines. And I'd like to thank all of the individuals who were part of that guideline development group. And in particular, highlight again the really important aspect that this, for the first time, is a joined up guideline between the WHO, but also FIGO and the International Confederation of Midwives, meaning that those who are on the ground have less confusion because there is less fragmentation of information. Before we start, just very briefly, thinking about the framework for reducing morbidity and mortality, there are, of course, risk factors or contributors in the background, such as low social status or poverty, maternal conditions such as anemia or infection. And then on top of those, you have to deal with pregnancy-related conditions, such as an antepartum hemorrhage or other risk factors that are pregnancy-related or placental-related conditions. And of course, health system-related pregnancy conditions, such as lack of quality antenatal care. Then you layer on top of that aspects related to labor and childbirth, so risk factors that happen during the birth, such as obstructed labor, for example. And finally, postnatal care. And if you think about postpartum hemorrhage and think about those women that come to risk, what you have is a Swiss cheese effect, where you have rarely just one thing going wrong, but perhaps a pathway, if you like, that goes from morbidity because of a collection of factors running through social determinants, through maternal conditions, through pregnancy, labor, and into the postpartum period. And the aims really of the interventions and the strategies for intervention are to try to prevent moving down this pathway, if you like, from one to the next. And we do that by intervening at the appropriate time, by preventative measures, by early diagnosis, and we'll come back to that, and of course, by rapid first response treatment, both of early and refractory management. So my task today is to talk you really through this aspects and to think about postpartum hemorrhage as a problem that is a problem where we are fighting against time. So time to diagnose the condition early, time to treat the condition early, and time to escalate properly, quickly. Because when women come to harm due to postpartum hemorrhage, part of the problem is the hemorrhage itself, usually compounded by the time it takes to act. So I'm going to run you through the recommendations that are in these new postpartum hemorrhage guidelines. And you can look at the recommendations as those that are revalidated, so existing guidelines that haven't changed, and also those that have had some editing, for example, existing recommendations where there has been edits to clarify the text, but no major change. And then there's those that are updated and those that are new. And really what I want to do today is to talk to you about the updated and new recommendations, because time is too short to go through all 51 recommendations. Really want to just concentrate on those that are updated and new. And we're going to look at these different chapters, if you like. One is the prevention and diagnosis, prevention due to trauma, prevention during the third stage. Then we go over to early identification of PPH, first response treatment, refractory management, postpartum hemorrhage, supportive care, and finally health systems interventions. So let's start our journey then on this prevention stuff. And we have the 4 main recommendations, and the new one that is important for us all to be aware of is a new recommendation on intravenous iron to treat iron deficiency anemia in pregnancy. This is a new guidance that was not there before. And it tells us that intravenous iron is recommended over oral iron in those women where oral iron cannot be used because it's not tolerated, for example, or, and this is important, there is a clinical need to correct the anemia very rapidly, provided, of course, intravenous iron can be given in a safe environment. In other words, the woman can be monitored for prompt identification of anaphylaxis, which is fortunately relatively rare. And I wanted to highlight this second part, the clinical need to correct anemia rapidly, because this is a scenario we sometimes come across where a woman is in the third trimester with severe anemia, maybe has not been able to tolerate iron. And we all know that starting oral iron at this late stage of pregnancy is good, but will unlikely resolve the anemia by the end of the pregnancy. And therefore, intravenous iron is preferred in that. Move to the next chapter, which is prevention of PPH due to trauma, and an updated recommendation on techniques to reduce perineal trauma during vaginal birth. Tells us that for women in the second stage of labor, what we can undertake is techniques to reduce perineal trauma and at the same time facilitate spontaneous birth. And these include perineal massage, warm compresses, and hands-on guarding of the perineum. These, of course, are based on a woman's preferences and the options that are available in that setting. We move to the third chapter, which is prevention of bleeding during the third stage. And this is a key chapter, really, because here's where we're talking about those ureterotonics that are recommended for the prevention of PPH and also those that are not recommended. And we will go through those briefly. So as before, as we all know, we want to use a uterotonic for the prevention of PPH during the third stage for all births. Okay, so remember, this is now prevention. This is not treatment. So for every woman who has a birth, what we want to do is prevent postpartum hemorrhage. And we do that by giving one uterotonic, oxytocin, carbetocin, or misoprostol. But they are very strictly in a hierarchy. So the recommendation, the oxytocin, the agent of choice that is to be given is oxytocin, 10 units intramuscularly or intravenously for all births. But of course, oxytocin does require a cold chain delivery mechanism, and therefore carbetocin is recommended when heat-stable carbetocin is recommended in those settings where the cold chain cannot be guaranteed. Misoprostol is recommended for the prevention of postpartum hemorrhage really only in those settings where oxytocin or carbetocin is not able to be given, and this is particularly relevant for remote home births. Importantly, uterotonics that are not recommended for prevention of PPH are also mentioned in this guideline, and they include ergometrin and methylergometrin, as well as combinations of oxytocin and ergometrin, which are relatively commonly used. And the reason for this is that ergometrin has significant side effects and does not seem to improve the prevention action of oxytocin over and above when looking at the data overall. Injectable prostaglandins are not recommended for the prevention of postpartum hemorrhage, and we will come to the treatment of postpartum hemorrhage at a later stage. So oxytocin and carbetocin, yes. Misoprostol in those settings where those cannot be used. And then here we have the list of non-recommended PPH agents for prevention: ergometrin, fixed combination doses, and prostaglandins. While we are on the not recommended, a new non-recommended preventative measure is tranexamic acid. Now, it's very important for you to remember, of course, that the tranexamic acid and some of the other agents we've talked about will recur at a later stage when we talk about treatment of postpartum hemorrhage. So highlighting again the top line here that I'm talking here about preventative management. So tranexamic acid not recommended for prevention at vaginal birth or at cesarean section. Yanis has already talked about the next chapter at some length around identification of PPH, and this is really such an important aspect, and in my view is an intervention in itself. The use of optimal diagnostic criteria for identifying the PPH in the first place is so crucial, because if you think about treatment, a treatment may be very effective, but if you're not giving it to the right population, or if you're only giving it to a small proportion of the population, then that effective treatment is rendered ineffective because it's not given to the right population, to the right women. So having these optimal diagnostic criteria is so important. And just as a reminder here, the new definition of postpartum hemorrhage is now twofold. So an objectively measured blood loss of greater than 300 milliliters, together with abnormal hemodynamic signs, a pulse rate of greater than 100, a shock index of greater than 1, systolic blood pressure of less than 100, or diastolic blood pressure of less than 60. Or, and this is an important word, or objectively measured blood loss of greater than 500 milliliters, whichever occurs first. Okay, and this, I think, is a departure from what was before, but also I think most of you who are clinicians in the room today will recognize clearly that a person who has 300 milliliters blood loss and there are signs, there is tachycardia, there is hypotension, there is shock, you should not wait until 500 milliliters to start that next level of treatment. Because if you do, wait until 500 milliliters and then go and find the postpartum hemorrhage trolley and try and find the IV fluids and the injectables and everything else, this is where we lose those crucial minutes of time for treatment of women and prevention of adverse outcome. I can tell you as chair of the committee that these very round numbers of a pulse of 100 and a systolic blood pressure of 100 handily were actually exactly the cutoffs that came out from the data. So Yanis already talked about definitions based on expert consensus and other things. And, you know, I was pleased actually that these numbers were round because they are easy to remember, but they were specifically came out from the data themselves. We've diagnosed the PPH. Now we go to first response treatment. And there are a couple of updated guidelines here, but this is the only chapter where I'm going to go to one revalidated recommendation. And I do that because it's relatively recent and also it's so very important. The care bundle for first response PPH. The care bundle for first response PPH changes what we used to do. We used to give one agent, and if it didn't work, a second agent, and if it didn't work, a third agent, and so on. All the time fighting against the clock. However, what we are now recommending based on the information from the large randomized trials that have gone on in this space is a bundled approach of motive, massage of the uterus, O, oxytocin, T, tranexamic acid, I, IV, intravenous fluids, and E, examination and escalation. So please remember that the treatment for postpartum hemorrhage has now moved away from the single agent at a time and is recommended as this rapid institution, I repeat it, uterine massage, administration of an oxytocic agent, tranexamic acid, intravenous fluids, examination, and escalation. And this is a very important aspect of rapid treatment. So not only are we recognizing the PPH more quickly, we are also treating the PPH when it occurs promptly and with multiple agents at the same time. There are in this chapter of first response treatment a couple of updates. One is on uterotonics for treatment of retained placenta. And the recommendation is to administer uterotonic agents in the treatment of retained placenta only in the presence of PPH. So if there is no ongoing bleeding, uterotonic agent is not necessary. And in a sense, you could argue that this is an unnecessary guidance because that uterotonic agent should be given already anyway if you have PPH, but it was important to reach this clarification. And when we have a manual removal of the retained placenta, routine antibiotic prophylaxis is recommended in all cases. Initial treatment of PPH works in the vast majority of cases, but as we all know, some women have refractory PPH, so ongoing PPH, and there are three important updates here, three important slides to go through, two of which are new guidelines and one of which is an updated guideline. I will go through the news first. Sorry, I'm not. I'm going to go through the update first, which is the use of uterine packing. I apologize. So use of uterine packing with gauze is not recommended. And that's the same whether it's plain gauze or gauze impregnated with hemostatic agents. And the reason for this recommendation or this recommendation against the use of uterine packing is that there are significant side effects, and the effects of uterine packing on PPH have not been proven. New guidelines then, one is the criteria for initiation of blood transfusion. So for those women who are experiencing acute or ongoing PPH, initiating transfusion should be based on an overall picture. So the underlying risk, the continuous clinical assessment, hematological assessment, and of course, a clear protocol for optimizing blood products. And finally, in this refractory management aspect, we have the use of cell salvage. Cell salvage is used in many settings, but actually the evidence for use of cell salvage is not very clear. It is also associated with a lot of expenditure and therefore is recommended really in the context of ongoing research and evaluation. We reach the next chapter, which is postpartum hemorrhage supportive care. And similar to the recommendation in the antenatal anemia and iron supplementation guidance, we have here postpartum IV iron and a new recommendation on intravenous iron over oral iron therapy for those women with anemia after birth where oral iron cannot be used or is not tolerated, or indeed again, when there is a clinical need with severe iron deficiency to correct the anemia rapidly. All the time, of course, this has to be in the context of trained staff who can evaluate and manage anaphylactic reactions, which are fortunately not common. Health systems are very important in terms of ensuring that all of this is able to be taken up. So we have revalidated or edited the existing recommendations on the need to have formal postpartum hemorrhage protocols in facilities, referral protocols, undertaking regular simulation drills, and also the monitoring for use of uterotonics. These are not new, these are existing, and you will be very familiar with the majority of them. So I'm going to just plug one more time the consolidated guideline. You can find it easily online. I've given you today a condensed highlights of some of the extra recommendations that come out of that. But please go and have a look if you're interested to see in more detail the methods. Importantly, all the supporting evidence is linked to there. There are a number of research recommendations which are very helpful, in particular for those research active institutions that wish to contribute and supervise people in undertaking high quality research. There are many, many ideas there. Implementation and dissemination, absolutely key, and the applicability of these guidelines. We wrote an opinion piece in Lancet Global Health relating to the launch of these PPH guidelines together with colleagues from the WHO, FIGO, and ICM. And the concluding remarks of that opinion were that postpartum hemorrhage is about time, as I've come back to repeatedly in this talk. Postpartum hemorrhage is about time to recognize, time to act, and time to escalate. And I think that this consolidated guideline should save time and therefore save lives. What is really the test now is whether the healthcare systems around the world and you, all of us on this call, are able to move fast enough to implement these guidelines. And I call on all of you as interested parties in the room. You are the people who are going to make this happen. There is no one else who's going to make this happen. So I thank you for being here and giving us the attention in order to ensure that we don't spend time and therefore save lives. Thank you very much.
Okay, thank you, Iris. My name is Sherry Evans. I am a midwife by training, a doctor of public health. I know many of you. And what Iris said is so important at the end. We can have the best guidelines out there. They are robust, they are evidence-based, they are comprehensive, they are consolidated, they are supported by FIGO-ICM, WHO working in partnership. But we know that if we can't get that care to the bedside, the implementation of those guidelines is not going to happen. Now, recognizing that training and the health workforce is very important, it is not the only thing, but we're going to focus on that piece right now. So I'm going to tell you a little bit about a new course, Bleeding After Birth, a course on prevention, early diagnosis, and treatment of PPH in order to align with those new guidelines. So how do we build capacity of the workforce to prevent, detect, and manage postpartum hemorrhage or any other complication?
Hi, Sherry. I'm
Yep.
I'm sorry to interrupt. We actually can't see your slides.
Okay, let me try that again. Let's try again. All right, are we back in business?
Yes, we can see you. Thank you.
Perfect. Okay, thanks. So how do we build the capacity of the workforce in order to implement those guidelines? Typically, we use offsite conferences, workshops where we bring a bunch of people together, we lecture at people, we give them things to read. There's often limited or no hands-on practice. And we've found that that really is not very effective. There are a number of studies out there. This is an older one at this point, but in 7 sub-Saharan African countries, training and supervision did not meaningfully improve the quality of care for pregnant women or sick children using the standard approach. And again, even with supervision added on. So, what do we know works? And this has now been out for, over 10 years. We know that simulation-based training, that it's case-based, that it's on-site, that it's interprofessional team-based, that it's smaller doses of clinical information delivered over time and practiced repeatedly really is what changes provider performance. And also media can enhance effectiveness and efficiency. So we call this, many of you have heard this term before, the low dose, high frequency approach to training, which again is that facility-based hands-on approach with manageable amounts of learning. So that's the dose at appropriate intervals. That's the frequency to everyone. And we know that it's important that that is followed up by short and repeated skills practice or quality improvement activities after the initial training. So this is what we actually did in the emotive trial. We used this very same approach of on-site interprofessional training, and the results of the emotive trial are quite clear. So we were able to build the capacity of the workforce in the trial sites in order to deliver the intervention. So in partnership, WHO in partnership with FIGO and Laerdal Global Health, with inputs from FIGO-ICM, UNFPA, created this new bleeding after birth course on prevention, diagnosis, and treatment of postpartum hemorrhage. Some of you will have seen similar training algorithms as this, again, designed to be delivered on site. And these are available for all of you to download. Here's the QR code. You can snap that. These resources are available online now, and they will be coupled with the Academy course. And so there's an e-learning course that WHO created in partnership as well. You can access a version of it now, and I think the final version will be up very shortly, but go ahead and have a look and check it out. A couple other resources for you. So the Magic app, some of you may be aware of this, but this is an interactive platform where you can really explore the guidelines. So not just the guideline itself, but you can have access to all of the evidence synthesis, everything behind these recommendations, and really get to understand how some of these decisions were made. So coming soon, there's an implementation toolkit. So again, training is just one piece of many. It's an important piece, but how do we translate those recommendations into guidelines on the ground? We expect to have this done by the end of this year. And we're actually piloting in Uganda later next month, the version of the toolkit that we currently have. So I want to thank everyone, and I want to turn this over to Professor Anne and Professor Jacqueline to moderate the Q&A. Thank you.
Thank you. Thank you, everyone. And thank you, our esteemed speakers. You've done a great job. But the questions are coming fast and furious. So I want to open it back up and immediately start by asking what's come severally. Measuring the amount of blood loss. How do I do it right? So maybe I will start with Iris. Maybe you can respond to that.
So thank you, Anne. I mean, I think one of the crucial elements that's been shown time and again is that visual estimation, or eyeballing as I call it, is such a poor method of measuring estimated blood loss. And what we need is objective measures of blood loss, moving away from purely visual estimation to more objective estimation. And this is also concordant with the data that this analysis is based on. As Yanis was saying, those data that were unable to have some kind of objective nature were actually not included in this analysis. An objective measurement by using a drape A calibrated drape, preferably with an action line, is by far and away the easiest and most effective way of measuring the blood loss more objectively.
Thank you.
And
I'll
there
come
are
to
other
Femi.
methods.
Yeah, there are. I'll come to Femi. People are still complaining heat-stable carbetocin is out of reach financially. What are the steps being taken by WHO and the regional hubs? I'm even giving you half the answer. So what are we doing to actually bring down this cost? Because we need the drug. We must have the drug. Where we have cold chain interruption, this is a golden drug for the areas that suffer from that. So what would you advise and what's really happening?
Thank you very much. I think at the very beginning, when the heat-stable carbetocin innovation came about, and before WHO engaged in the champion trial that sort of generated the evidence behind it, WHO insisted with the manufacturing company the innovator of heat-stable carbetocin to establish a special price should the medication be demonstrated to be non-inferior to oxytocin. So there's a live, it initially used to be tripartite agreement between MSD for mothers, Ferring Pharmaceuticals and WHO, but now it's bipartite agreement between Ferring Pharmaceutical and WHO to ensure that heat-stable carbetocin is introduced into roughly 88 countries with high burden of maternal mortality, most of this coming from postpartum hemorrhage. And that price is at closest as it could be to the oxytocin as sold by UNFPA. What has happened over the last 3-4 years is that the innovator of the company has made effort to introduce the medication into several countries, but this has been quite challenging at the regulatory level. At the moment, up to 35 countries or thereabout have had heat-stable carbetocin introduced, approved through the regulatory agencies and made available. So I think the issue that I think what we need to do is to sort of support regulators in the various countries that are still struggling to get the approval that is needed. I think the company has submitted their dossier to several of these countries, but it's a bit of an issue, especially in LMICs to get these approvals. But the carbetocin that is sold, the general, the non-heat-stable formulation, I agree with the people who put the question. They're still expensive. It's close to 20 times the cost. But for private sectors in approximately 80 plus countries, heat-stable carbetocin should be available over the next couple of years. Over.
Thank you. So Jackie, get prepared with your question, but I'll ask one more. We talked about massive blood transfusion and the protocols that should exist. I'll go back to Aris again. So people are asking, what is the role of having blood and blood coagulant factors in the management of a patient with refractory PPH?
So I think there's two answers. There's an answer of what does the evidence show at scale, and are there randomized trials demonstrating that fractionated blood products or specific fractions of blood are useful in randomized trials and can make their way into guidelines. And then there's the evidence on the ground, if you like. And what for certain is true is that the administration of red cells is useful when you have large-scale PPH. Once we go beyond that, once we go into the realms of very large transfusions, really what we need to go is to individualized management. And I think all guidelines are going to be difficult to keep up with that. Here's where you need your hematological colleagues and your clinical colleagues to outline, the individualized management of the patient regarding additional use of fresh frozen plasma, platelets, or other blood products that may be useful. And you know, it is difficult to, if you like, go beyond the general statement that systems for blood transfusion should be available and knowledge should be available, and you know, difficult to outline exactly what products should be given in what a specific scenario. That's my take on it anyway. I don't know, Femi, if you have anything to add to that, more granular.
Femi, any comment? No.
No.
I think what's most important is at national level, you should really be working with your hematological group to actually know what sits as the best protocol within the context of what you have. Because we may give you a prescriptive, but is it perfect for where you are? Not all nations may even avail even that fresh blood that you really want, let alone the added blood products. So I think what's most important, prevention is better than cure. Jackie, over to you.
Thank you, Anne. And there's so many great questions in the chat. I'm going to select one that I'm going to direct toward Sherry. So, okay, get ready for this one, Sherry. This question's really broadening the responsibility, not just about the health professional, the OBGYN, the midwife, but also about others in our amazing architecture. And it goes something like this. Assuming the target audience for these guidelines is health practitioners, well, it's healthcare practitioners and more, but at the procurement and stakeholder part of this, for example, are they likely? They're unlikely, says this person, to read these guidelines. I think there's something in there. How is a healthcare professional to action this contextual use when they only see cold chain in their ward institution? It lands in somebody's space. And so the question is, I guess, how can others be involved in this journey to ensure that cold store is cold store at the point of use? And that's a question for you, Sherry.
Yeah, thanks. It's a tricky question because honestly, midwives, doctors can obviously advocate at the level of their facility, but they have very little control, right? And so that's more of advocacy, right? And also being part of your professional association and up through the professional associations that work with ministries of health to advocate for cold chain or the other options if cold chain just is not sustainable, to have appropriate uterotonics available. I don't know that really very much gets to the answer to the question. I think these guidelines are not just for healthcare providers, of course, as you said, and more. It's policymakers, and we need to advocate at the highest level with ministries and the professional associations to ensure that women have what they need when they give birth.
Thank you, Sherry. And just to give our speakers a moment of pause, I'll just read a question actually that's just popped up from somebody from the United Kingdom, a midwifery lecturer, no doubt, who has stating that really interesting, and thank you all so much. She was teaching, or he was teaching PPH to student midwives on Monday. And so it's really interesting to hear these recommendations, particularly the use of symptometrin and ergometrin as a primary uterotonic, as many UK trusts are using it as standard. So it's a question making a point. I think it demonstrates that we have a lot to do. These guidance are very new, and it will take time for the ripple effect to happen, not just the ripple, but for this to be implemented in practice. So, Anne, I'm going back to you.
I have a burning question for all of us. Human resource, workload to workforce. In fact, I want to point this question to Sherry. I'm in a labor ward unit. I have 80 patients. I have 5 who are actually pushing the baby out. 3 of those develop PPH. My hands are tied. My theater is only maximum 2 of them, of which only one I can say is functional. What do I do when I have that really dire constraint? Human resource to the workload, to critical care patients such as these who are coming down with PPH. What can I do?
I have to say it's an impossible situation as a midwife or a nurse or anyone managing multiple patients alone. I think all of us as clinicians have probably been in the state, no matter where we work, that potentially so many things are going on in the labor ward and it's you. And you're having to manage complications, maybe even over your head and without the support you need. I don't think there's an easy answer. I think basically the health workforce needs to be paid appropriately for the services they do to encourage more people to come into the profession. And then on a very most basic level, I have asked for help from family when, there's no one else around. And so tough question, not an easy answer. I don't know if any of the other panelists want to kind of weigh in on that really sticky situation.
Femi, WHO gives me a standard, 4.45 per 1,000. Maximum, I should be nursing or attending to 4 to 6 patients maximum in the labor ward. It's not my reality. What is WHO telling us to do?
WHO is telling us to ensure that women give birth where they could be adequately cared for. I think giving us a false sense of security, where one person is dealing with several patients is not ideal. I know it happens, but I think, systems should try to avoid those circumstances, because even though we know the risk factors for PPH, you don't know who's going to have postpartum hemorrhage. So if you're not equipped, if you can't shout for help, for instance, to get somebody else to assist you, you have no business, attending to that, delivery, or that, woman in front of you to give birth. So that's always been our position, skilled birth attendants. And that means having the right people, right number, the right place, right facilities, for giving birth. I know it's difficult, but we always try to, find the easy way out, and that's why women are still dying. Over.
So I will kind of put my voice in because I've dealt with this reality. And the first thing is, can we create a team culture? Team culture, my midwife, my gynecologist, we've got to know the constraints we have, but we've got to deal with the patients to give the best we know, which also means we've got to look at task shifting and task sharing. But I think the most important, which I have found in going around, even as the FIGO president, we have not been doing regular simulation drills. So we all go into panic mode when everything gets out of hand. I think in the last FIGO, we really demonstrated it's one major thing that can make a difference. Doing the simulation of resuscitating both the mother and the newborn that comes from the product of delivery. So I want to believe we also have a duty to be leaders. I've always said, anyone in a labor room, you are the leader at that point in time. Where you have constraints, shout for help, shout for numbers, let the evidence be presented. MPDSR is also there, and we have the SR, surveillance, response. But how many of us act on those two, S and R? We just do it as a routine clinical audit without saying, this is what we have found persistently, workforce to workload. Can you do something about it? So you have a duty, I have a duty to exercise leadership. That's what I want to hear. Jacqueline, back to you.
Excellent. And yeah, what can we say? I couldn't say it better in relation to leadership. But Ionis, I'm going to take this back into a space for you. And this will be a very easy question for you to answer, no doubt. Can hemocell, just slowing down here to get you thinking, can hemocell be considered because of its component and its indication use in the severe blood loss in addition to uterotonics?
I'm not sure what is hemocell. So there was that question in your question.
It's a colloid.
Polygylene? Yeah, it's
It's a colloid?
Yeah.
It's a colloid. Yeah.
Okay. So WHO recommendations in the context of postpartum hemorrhage is for crystalloids and not for colloids. Colloids are, I know that that's not included in the recommendations, but it's mainly for expanding blood volume in terms of managing shock or hypotension. But the immediate sort of first response include intravenous fluids, that it's crystalloids.
Mm-hmm. And I've got another question here, and I'll read it out, and then one of the panel might be able to answer it. I think I'm kind of selecting some of the questions that have been deemed to be popular by others, number one, with a few ticks, but number two, that are just a little outside of the box. So, in cases of home delivery, for prevention of PPH, could it be possible to supply misoprostol 600 milligrams during the last trimester or at 32 to 34 weeks gestation? And there's a supplementary sentence here. They should be PR or under the tongue, and I won't mention the person that's asked this question. So that's an interesting space, isn't it, in the home environment? Despite risk assessment, this is a home environment. Does anybody want to respond to that? Aris, I'm looking at you here, but
Can respond. There's a recommendation on advanced misoprostol distribution for prevention of postpartum hemorrhage. And I think that's what that question is speaking to. The evidence is not very strong, but there are programs already in several countries where home birth is prevalent, where women are given misoprostol packs to carry around with them during antenatal care. And if for whatever reason they have to deliver at home because they got snowed in or there was no good transportation to get them to the facility, then they can swallow the medication right after birth. And that's been, there was a study by Andrew Wicks and others, and there was a systematic review that I did several years ago that I updated on that particular topic. So it's correct to use that approach in scaling the use of uterotonics to places where home birth is very popular. Over.
Thank you, Femi. Really, really helpful. Anne, I'm going to come back to you, but there's just one little sneaky question here, and it has 3 ticks, so it's quite a popular one, and it's from somebody in Pakistan, and they're saying it's not a question. I guess it's for our panel to think about. It's a suggestion I'm reading here. Shouldn't we make measures to prevent PPH like preventative measures? Every pregnant lady is anemic. And the second, shouldn't we develop PPH team at each healthcare level with appropriate liaison with Next Healthcare? So, it's a point. I guess other people are reading this and liking it.
Yeah.
I don't know whether anybody's got a point to make, but I'm handing back to Anne.
I can comment on that. Anemia is very common, and particularly in LMICs where PPH is really prevalent. And I think, one, we need to start having women have planned pregnancies. And how do we do this? We've got to move upstream. Preconceptual care in a lot of our nations is still an enigma. Particularly, I'm looking now at LMIC. So that's one area we think we can put our foot in and begin to advocate. Then, bringing women into the clinics much earlier than when they present. The majority come in second trimester when the baby is already moving and they're certain that, yes, now I have a little one growing in me. It's too late to start putting in interventions. And again, this has to go not just with medications. We're talking advising on nutrition, taking the prophylaxis where you have malaria is endemic, dealing with chronic ailments, and even basic deworming programs, things that we can do, water and sanitation. These are measures over and above nutritional advice. But yes, this is the reason we're trying to push more and more people. Come for skilled care, come for skilled vet attendance, because then you take a proactive approach. I'll stop on that one. I'll come back to Aris. Aris, there is a question here that has fascinated me, and I want you to actually answer it. And it is in regards to the use of UBT, the use of devascularization procedures. When do I do those? When should I provide for them? There is even somebody who's asking about the vacuum-induced hemorrhage and the packing. I'm going back to the packing because we have packing with chitosan, impregnated chitosan gauze. Please break it down because I know there are people already ordering all this, and we need to hear the when, and if not, why not? Back to you.
Yeah. So listen, in terms of refractory hemorrhage, the units should be able to undertake additional procedures. So, and that includes, in the first instance, bimanual compression as a temporizing measure after vaginal birth. You can use external aortic compression as a temporary measure. You can use non-pneumatic anti-shock garment as a measure. The uterine balloon tamponade is useful in women who don't respond to standard first-line treatment after only in the case of uterine atony. So it is important that we exclude that there is a surgical, if you like, need, but it's a context-specific recommendation. So you can only really use the uterine balloon tamponade if you have recourse to surgical intervention and access to blood products if possible if needed, because there is a risk otherwise that you are using the uterine balloon as a temporizing measure, which is not really the intention of it. So the primary PPH first-line treatment protocol must have been implemented. Other causes of PPH, like retained placental tissue or trauma, have been excluded, and the person who performs the procedure has been adequately trained. If all those conditions are met, and that's why it's what we call a context-specific recommendation, then uterine balloon tamponade can be used. As far as uterine packing with plain gauze, or indeed gauze impregnated with hemostatic agents, the data, I'm afraid, are still not there, Anne. So I know that there's a lot of talk about it, and I know that people have, used it and use it. However, what is very clear in the available data is that uterine packing, be it plain packing or impregnated packing, there are no strong data to suggest that these are useful. This is what the evidence synthesis team found, and I call to those who wish to pursue that to undertake large scale trials in order to show whether these are useful, and that kind of work is possible, as has been shown with other interventions.
Thank you very much. I want to really appreciate my panelists. I want to even appreciate my co-presenter, Jacqueline. Ladies and gentlemen, we are 500. At one point, I thought I read 546. We're still at 524 participants. Kudos to all of you who have remained with us. But I think it's very clear. The guidelines are out, the implementation tools are out, the academy is there for you to gain knowledge. You have gained some knowledge this afternoon or this evening or this morning, but it's a beginning. We have a lot more to do even in the research arena pertaining to PPH, both prevention, diagnosis, and treatment. But what we would want is you to become the ambassador to disseminate these guidelines, to get into research caucuses or hubs so that we can even get a little bit deeper in terms of taking a deeper dive in understanding PPH. What is our main aim? Elimination of bleeding after childbirth. I think that still remains. We've got to do what we can within the context that we do have, but giving and providing evidence-based best practices. Jackie, do you have anything to say in your closing before we actually close off?
Just very quickly, I mean, you've said it all really, Anne, but I think, you know, this is a landmark. The consolidated PPH guidance is a landmark publication, and it's now time. It's not time to throw up our hands. It's time to roll up our sleeves and do something about it. A question that we didn't get to, Anne, was a question about midwives. How are we going to ensure, not everybody knows about this webinar, how are we going to ensure that we bring every midwife on board? Well, I would say it's about all health professionals in the maternity space. Midwives and OBGYNs, our midwives associations need to ensure that this guidance is known by everybody, disseminate it through your networks, talk about it, policymakers, strategists, ensure that you get this into healthcare policy, health system leaders. This needs to be in healthcare policy so that the person on the ground providing the clinical care has the tools required to save a life. Back to you, Anne.
Align MNH, thank you very much. As you can clearly hear, it's the beginning. So you have a lot more webinars to hold so that we can spread the word much farther and faster, much further and faster. We don't want to have maternal loss because it has very dire implications, not just for the mother, for that newborn who may have been left behind, for that family that has to deal with that loss, and for nations and productivity towards development. Ladies and gentlemen, I want to really sincerely thank you this evening and look forward to yet another webinar. So stay out looking for the next webinar on PPH zero rating. Thank you very much, ladies and gentlemen.